All right, it is time for the August. Why does healthcare suck? That's right. Why does healthcare suck? We dive into all of the different reasons why healthcare, in the mind of so many, is in such disarray. I came up with the idea of this particular series after reading a Harris poll that showed that 70% of Americans believe that the U.S. healthcare system has failed them in some way. That tells me that the system sucks. So we have to do better. We dive in every single month into different ways that we can fix things, how we can look at the problems, find solutions, and actively make healthcare better. I am extremely honored today to have a local San Antonio direct primary care physician with us, Dr. P. Dr. Priscilio Salas, as it were, goes by Dr. P, will be joining us today as we talk specifically about men's health. I had looked at some numbers to kind of give me an idea of if the way I felt and the way many other, I think the word on the street is, right, is that men see doctors less, that they are more likely to wait before they go to the doctor, that they don't spend as much time with the doctor as women do. And not surprising, all those are actually facts. As I went out and looked at all of that information, it proves over and over that men do not go to the physician as much. Now, there are a lot of things that are negative there as well, because men, why do we live less, right? Why is our lifespan as men typically less? Well, it's typically because we don't take as good a care of ourselves. I think one of the very interesting things that I found, and I'm really interested to hear your take on this too, Dr. P, is in the studies, some of the studies that I was reading getting ready for this, it said that men in general receive significantly less time with the doctor and get less of an explanation of what's going on. And I said, you know what? That's probably right, but it's probably our fault. We were just not really listening to begin with. So I kind of would like to start there. Has your experience been that not with you personally not wanting to give that time, but you, the man himself, maybe not wanting to give you the time to explain everything to him?
Yeah, Harlan, that's a very good point and a great question. And first of all, thank you. It is my honor to be on your show, by the way. So thank you for inviting me today. I think that, men's health and just health in general, but especially men's health, a lot of times and for many reasons, men don't seek care as much as perhaps women do. And as you said, that's maybe because of our own to our own detriment, I guess. And so, yes, I think on average, the average visit time across the board is about 7 to 10 minutes. Men are definitely on the lower end of that. I think, multiple reasons for that. Yes, men are less likely to go to the doctor. They're less likely to really talk about what's really going on. Most physicians are men. And so, man to man, you're kind of like, okay, well, yeah, you have high cholesterol, you have diabetes. Okay, here's your medicine. You okay with that? You any questions? All right, I'll see you in 3 months, right? Men are just more likely to not ask necessarily questions, but also to, just do as they're told, if you would, right? We're kind of used to that as men, right? And being in the workforce and et cetera. And that's across the board in most primary care visits. Very, very different, I will say, from a direct primary care visit.
Yeah, it is interesting. I agree with you 100% on even how my visits were until I became acquainted and started using direct primary care and kind of realized, hey, it's actually okay to ask some other questions, right? Mm-hmm. Because in the traditional system, it's not, which is kind of weird. You can't ask those other questions. A lot of times they're like, oh, well, you need to set another appointment if you want to talk about something else. You don't get to talk about all these things. Well, you know what? By the time I get another appointment with you, I'm either cured or dead. So, whatever, I mean, if you're not worried about it, doc, then I must not be either. And it really is almost that way, right? If you think that I can wait till another appointment to talk about this, then it must not be that big a deal. Okay, my doctor. Well, hey, when I get home, well, what your wife asked? Well, what did the doctor say about it? He said it was no big deal.
Yeah.
That's what I got. That's not what he really said, but
Right.
that's what I inferred from it. Is
make an appointment 3 weeks later, and we'll talk about it then.
But you're right. It's very interesting to me that we have put ourselves in this situation where I think that we kind of what you said, we do what we're told. And many times we don't question the doctor. I know for a fact that I don't question the doctor near as much as my wife does whenever we're talking about stuff, but we don't ask enough questions either. Right. So it's an interesting thing, right? If I do have questions, I have become much more accustomed now to asking those questions since I started working with direct primary care over the last few years. But before that, if it wasn't hurting.
Yeah. And that's basically, what we're used to, not just as a society, but just the healthcare system in general is made
right.
Like that, right? The healthcare system is made to be reactive. That's a whole premise of insurance, is use insurance when something happens, right? Now, a lot of things happen because we're human, right? Whether it's a cold, an ankle sprain, a physical, a colonoscopy, I mean, you name it, there's so many things that can happen with any one particular person. But the system has become just so overly saturated with reactivity and just being reactive that, it ends up burning itself out, burns out the doctors as well, who are seeing 2,500 to 3,500 patients per physician in a traditional practice. And so you have very limited time to ask those questions. And unfortunately, that's where the money savings is. That's where the life savings is in that prevention.
Yeah. And so, what we're talking about here in the traditional system at this point is sick care, kind of just what you said. We don't go to the doctor. We don't have enough preventative care. So it's reactionary. I don't feel well, I go to the doctor. I might not have to feel well for a few days, and then I go to the doctor, depending on who the person is, the kind of job that they have.
Right.
They may never go to the doctor, right? Or it may get to the point where it's significantly worse. That's another thing that I had, kind of study on this. It's much more likely that a man will delay things until they're more serious, and therefore the direct result of that is higher healthcare cost overall because you're waiting till things are worse. It could have been an easy fix, but now it's going to be a little more complicated. Maybe there's procedures involved. Maybe there's, higher levels of medication. It's not going to be a low level medication. That's going to be a more expensive medication, those type things. But what we're talking about now, what we really want to focus on today is taking that next step, right? Manning up to medicine 3.0, which is what you are a specialist of in the primary care world, is that next level of medicine that is not sick care, but really keeps you at peak performance for those who strive to do that.
Exactly. And I think the phenomena of medicine 3.0 was born precisely because of that, right? Precisely because the healthcare system was, built to be more sick care. So think of it as medicine, 2.0, or if we go way back, there are several physicians that have talked about this more prominently. Dr. Peter Attia up in Austin, but medicine 1.0 is the discovery of, hey, we have bugs, right, that can cause disease, for example. Okay, well then what do? All right, medicine 2.0. Well, let's treat those bugs, right? We have antibiotics, we have, clean the wounds, et cetera, and then maybe do a little of prevention in there, throw some cancer screening, some colonoscopy, prostate cancer, breast cancer, things like that. But it's not really, meant for big prevention. So medicine 3.0 comes in and says, hey, let's not just do the basic cancer screenings that we know can save lives for sure. But let's do more than that. Let's focus on truly personalized medicine, truly optimize your health and improve not only your life or your health, but your health span. How many years you're actually living that are healthy years rather than sick years. That's truly the premise of medicine 3.0.
Yeah, it's funny. You were talking about we have bugs. I was watching this docudrama type thing, and it was about the instance or about the time period anyway, when someone came up with this idea that when you're doing surgeries, you should wash up. You should wash your hands. That there may be something to having clean hands that will help you not to get the dirt and whatever into the patient. And then the idea is, well, maybe we should wash the patient area where we're doing this, and there's open. Well, maybe we should wash that area and wash our hands. And every step that they took in this mindset, the outcomes were better, right? The outcomes kept getting better. It's what is so interesting to me about that is how in the world did we ever think it worked any other way, right? In today's society, today's world, today's medicine, you're like, this is just basic logical things. Mm-hmm. But it wasn't, because if you don't know, you don't know.
Right.
But the reactiveness that medicine is right now, which it has been for a very long time, right, Dr. P? We have been in medicine 2.0 for a very, very long time.
Mm-hmm. Very long.
And the fact that we haven't, some, right, there's some doctors such as yourself that have been practicing 3.0 for a long time, but overall, and the entire healthcare system is still in 2.0. Mm-hmm. We just have, unfortunately, we have some outliers such as yourself and many other direct primary care doctors that are practicing a different medicine the same way back in the day. Some people said, hey, why don't we just wash our hands? What a novel concept, right?
Right. Let's try that. Let's wash our hands, wash the instruments, wash the patient area, instead of going from the morgue where we're doing an autopsy straight to delivering a baby without washing your hands, and maternal deaths were going up and infections were going up. It's like, let's just wash our hands in between what we're doing. Let's try that. But the premise of that is it's prevention, right? It really was prevention. It was reactive because of what was going on, but inevitably it became prevention. Hey, let's prevent the infection, right? Let's reduce the infection rates, and therefore you have less deaths overall.
Right. So how difficult is it to get men to buy in to this? Because we're reactive. It's already, the numbers already tell us we don't go until we're sick.
Yeah.
How difficult has it been to get more men to buy into the preventative, the let's get you well before you're sick kind of mentality, right? Let's keep you well. Let's not you get there, but let's do the things that we need to do to keep you from getting to that point.
Sure. Yeah, I mean, across the board, men or women, it can take some time, but you're right, especially with men, it takes a little bit longer. Again, societal norms, we're in Texas, so, machismo, different things like that. Oh, well, I can handle this. I don't need, to take those extra steps to prevent things or to keep this from getting worse. I'm just going to keep chugging along until I basically fall on the ground and die. But we forget that falling on the ground and die process sometimes actually takes a very slow and expensive decline. Expensive not only financially, but also on you as the person going through that, your family, your employer, your friends. I mean, it takes a toll on a lot of people. So it does take quite some time. Now, again, I will say that it's taken a little less time in a direct primary care model, because precisely that time, we have the time to talk to our patients. I'm very good when somebody comes in, especially a new patient. I can read them, pretty quickly as to how open maybe they will or won't be. And, I start asking some open-ended questions and just start probing, let them open up. And my initial, visits are an hour, sometimes an hour and a half with a new patient. It takes sometimes that much time to even just break through, that resistance wall, that barrier that keeps mostly men, from truly opening up to anybody.
Yeah, I think that's a great point because, as we kind of talked about before, in the traditional system, you don't have much time to talk.
Mhm.
And there's very, very little times that you have a relationship with your physician because of the way the system is now. I mean, interestingly enough, most people, you ask them who their physician is, they'll tell you who their doctor is, but a lot of times they never have seen their doctor or they haven't seen their doctor in years. They see the physician assistant or the nurse practitioner. Nothing wrong with that. But if you want to be honest, that's who your physician is now, or that's who your doctor is, or that's who your clinician is. It's no longer the person whose name is on the door because you're not seeing them.
Right.
They're not taking care of you anymore, as it were. But the point there is when you're not building those relationships, you're less likely to open up about all the things that are going on. Very difficult to have medicine 3.0, very difficult to have preventative care, very difficult to even treat the things that are going on if the doctor doesn't know what's going on.
Sure. And don't get me wrong, sometimes things can be relatively simple and the visits can actually be just 5 or 10 minutes. I mean,
sure,
not every visit has to be 30 minutes to an hour, but if you need that time, then again, in direct primary care, we have that time. We can give that time to our patients to open up. Maybe it's not the first visit. Maybe it's the next visit. Maybe instead of, hey, you know what, we ran out of time today, but I really think we should talk about this. Guess what? I'll see you tomorrow, or I'll see you in 2 days, or I'll see you on Monday. But I'd rather talk about this sooner rather than later, not 3 or 6 months down the line.
So having that extra time, building that relationship, sometimes, as you're kind of mentioning there, maybe this person is not ready for an hour and a half. Maybe they just need a 10, 15 minute just to make, to really understand that you're not going to bite them, right? The old thing, oh, don't bite, okay? That it's not going to be a painful thing. You just are there to help them. How often do you find that as you move through that process and build that trust, that you're uncovering not just other medical issues, but maybe some mental health issues, especially with men who don't, remember, rub some dirt on it, or we don't talk about those things, and men don't cry. And like you said, we're in Texas, but it's kind of a wide-ranging thing anywhere to a certain degree that we don't talk about those things, and we suck it up, Buttercup. And those, how often are you then running into and able to address mental health issues that someone didn't even realize particularly that they had? Mm-hmm. They might have, but
Mm-hmm. Yeah, it's a very common issue. I'm not saying everybody has a mental health issue or problem or illness, but it's something that is very important for us to especially uncover, because if you think about it, in order to make a change of any kind, you have to be in the right headspace. You have to be in the right mindset in order to make that change, right? Otherwise, then it may seem like it's very difficult. It may seem like it's impossible. It may seem like, well, that's just the way it is. Maybe I'm the problem. And so more often than not, in fact, in every single visit that we have, so a little bit extra background before I move that. Answer that question. I practice primary care in the direct primary care model, but I also specialize in lifestyle medicine. And so with that additional specialization and certification, we really employ the 6 pillars of health into basically all of our visits. And the mental health aspect is sort of woven into those pillars of health, primarily in the stress pillar. We always talk about stress and what's causing stress and how patients manage stress, but also the social connectedness pillar, because we, especially after the pandemic, realized that, hey, we truly are social people, and social isolation was not a good thing for many. And so having a positive social environment at home, at work, etc., plays into mental health. So we go through all those pillars of health, and sometimes we're talking about exercise and we actually uncover some underlying mental health issue that might have been going on. Same thing with, maybe we're talking about sleep, and it turns out that the sleep issue is because there was a mental health issue going on. And so we're able to talk and uncover those things, sometimes not directly, but tangentially, if you would.
In amongst all of this, direct primary care, in my mind, what I have seen in my overall relationships with multiple doctors is how big a difference it can make in chronic illnesses. Chronic illnesses, that there's a wide range of things there, but what we see in the traditional system is most chronic illnesses at the primary care level are then referred to somebody else because they don't have time, right? If you only have 5 to 7 minutes, which is what a primary care doctor typically has, that's the average time that they have with a patient whenever you're in that direct, when you have insurance and you're in that, you're working for a private equity firm, you're working for an insurance company, or you're working for a hospital system, your direct primary care doctor usually has 5 to 7 minutes. That's what the average is. In that case, they literally don't have time to take care of chronic illnesses. So they have to push you out to somebody else. Well, what we then see is a less likelihood of people going to the doctor. They may get that referral, but they don't do it. If they do, or if that doctor doesn't send them, but they just put them on a medication. Well, here, you've got pre-diabetes. Let's go ahead and put you on some metformin. If that's all that happens, we see the adherence to medications plummet. People simply don't do it. What has been your experience with your patients in not just working with chronic illness, not just maintaining it, but reversing it? I cannot believe how many people have told me I've got diabetes. I've been told by my doctor I'll have this for the rest of my life. It's not reversible. Well, BS, folks. I'm just going to say BS. You better get you a primary care doctor. You better find someone that knows what they're talking about, because as long as you're going to the doctor you're going to now and just taking that medication, you are 100% right. It is not reversible. It is definitely lifestyle modification that you need, not just another medication. So talk a little bit, not just on diabetes, but on multiple different chronic illnesses that people may encounter that can be handled in a different way. And of course, we're not just talking about men now, but with men in particular, because they don't seem to find any other way except their doctor said, take this medication. They said, okay, I'm taking this for the rest of my life. That's not always the way, Doc.
Right. No, definitely not. I mean, in our practice here at Salvi Direct Care, again, being direct primary care physicians, primary care, most of all, family medicine, lifestyle medicine, you're right. It's total BS. We've been able to, in fact, reverse a lot of these chronic conditions like diabetes, like high cholesterol, high blood pressure, obesity, for crying out loud, as well. And so, yes, to some extent, medications can be an aid to get you there. Sure. But At the end of the day, lifestyle has to, more than anything, change, right? Because especially with metabolic diseases like diabetes or even high cholesterol, the vast majority of the time, it's lifestyle induced. It's something that we're doing or not doing that is causing the sugar to go up, that it's causing the insulin resistance, that it's causing the cholesterol to go up, the plaque to build up in your arteries and blood vessels. And so sometimes, again, identifying that can take time, right? It's not always overnight. I mean, changing a habit can be very, very difficult to do. You need to do, it can take 7 weeks, 7 months to change a habit, depending on how motivated the person is. But we have been able in my practice to take people off of insulin for diabetes. We've been able to take them off completely medication for high cholesterol. Even some patients that have seen improvement in their heart disease as well, as long as they're willing to put in that time and effort to make those lifestyle changes.
So another issue is just complete avoidance right? So, another study that I read said 65% of men would rather delay or avoid a visit. I might have set it up, but I think I'll cancel that, or I think I'll delay that, or whatever. What have you done to, here's the carrot, right? Come see me. Come see me. What have you done to help engage men, particularly men, to be more involved in their health? They should, right? I mean, quite honestly, there is nothing we have that should be more important to us than our health. Without that, you ain't got nothing else. You can say, oh, but my family. Well, you ain't gonna have a family too much longer if you ain't taking care of yourself there, buddy. But how are you engaging with them or getting people to come see you a little more often? I know it may be incremental, but what processes do you have to help men make the right decision to not put this off anymore and to take care of themselves?
Sure. Well, this might sound like a broken record, but time, right? So having the time, giving each patient the time that they need for whatever it is that's going on at that moment. Other things that we employ is, hey, in the direct primary care model, you're paying one flat monthly fee. So we can have a conversation as often as we need to, and you're not having to pay a copay every time you come and see me, whether that's in person, by phone, by text. I have plenty of patients, especially men, that will do visits just over the phone. We'll have a visit over the phone between their lunch break or between meetings, for example. So access is the key, right? We're giving every single one of our patients access to talk to us as their physician, because again, these things take time, right? Habit changes don't happen overnight. So I'll send them periodic messages. We have secure ways of communicating with our patients about, hey, how's that, if we did start a medication, how's that medication coming along a week or two later once you started? Any side effects, any issues? Hey, we're starting on a new nutrition plan that we customize for you here in my practice. Are you having any issues, any difficulties? Were you able to did you understand the grocery list that we provided to you and the portion sizes, for example? So those check-ins, right? You have someone, I heard somebody say that in direct primary care is like having a doctor in the family, or like having the doctor in your pocket, if you would, because of smartphones and smart apps and things like that. So we're constantly reminding our patients that you have access to us. Plus, we're also having those checkpoints and check-ins with them periodically, instead of just, again, here's the medicine. Just make sure you're exercising and you're eating better. Okay, I'll see you back in 6 months. Right. That does absolutely nothing, because that patient leaves the office in that traditional visit. Okay, well, how do I exercise? What do you mean eat better? What am I supposed to eat or not eat? And so it tends to create more confusion. And to your point earlier, never mind, they either stop filling the medication, or maybe they do, but then it just falls off after a while.
Right. Yeah, I forget to take it. I've never had to take medication. I forget to take it. And then I get a couple of days behind. I'm like, I don't even feel any different. Well, I mean, think about this, especially with like blood pressure medication. Typically, you don't feel any different, right? You don't feel any different at that point in time. That's why it's called the silent killer.
Mm-hmm. Exactly right. Exactly. High blood pressure is that silent killer. And so you may have absolutely no symptoms, and before you know it, you just had a stroke or a heart attack.
Right. And it's so easy to not take your medication. Quite honestly, it's easier to not take your medication than it is. I want to just pause for just a second. And I put it up on the screen as well, folks, but in case you're listening, if you have any questions, please put those in the chat, and we'll be happy to answer those as we go along here. So just type in your questions or comments in the chat. I'll be happy to share those on the broadcast here. So as we're kind of moving forward in this, I think about the different things that we've covered, and I think about overall, I think the numbers also prove out from what I saw, that, and this is not surprising because of the type of things, activities that men do, we're more prone to accidents. Okay? So you look at, we're more prone to accidents. We're more prone not to follow doctor's instructions. We're more prone not to go to the doctor. You put the list on all these things. You're like, well, there's just no. It's not surprising that we don't live as long as women, right? It's not surprising that it happens that way. But we also see another side of that, and that is almost like the societarial. Is that even a word? I don't know. It is now. Societarial peer pressure of being tough and not going to the doctor, right? Like I said earlier, rub some dirt on it. You're not really hurt. Men don't cry. All of those things. So in a very real way, what we're doing to ourselves and our health is our own fault. We're allowing society to keep us unhealthy in many cases because we're just listening right to the way it's always been instead of moving forward and saying, you know what, I'm going to take control. I'm not going to listen to that. I'm going to take control. I'm going to spend the time with my doctor. I'm going to work with my doctor, with my physician. I'm going to develop a plan. I'm going to follow that plan. I'm going to make the recommended changes. We're going to decide what is right for me. I'm going to make the lifestyle changes that help improve my overall health, that will then help improve my value to my family and to my fellow man. It's an easy, logical step to take, to think through, to plan, but it's a little more difficult to actually take that action. As people go through this process of saying, I want to take action. I mean, obviously we're listening. There's people going to be all over the place listening to this. Is there any reason why they should not reach out to their local direct primary care physician? I mean, is there anything beyond that I know there's lots of other things out there, but can you think of any reason why a good place to start would not be with the direct primary care physician?
Yeah, I mean, obviously being in direct primary care, right? The answer is yes. However, as we were talking about earlier, there are lots of great physicians out there in the traditional, system. I mean, I was one of them, right? I was in the system for several years. In fact, my first practice was a traditional insurance-based practice, and so that's kind of how I got into direct primary care, because I just could not spend 7 minutes with my patients. I mean, I think most of my visits were at least 30 minutes. Yes, unfortunately, most of my patients had to wait, but I was trying to answer their questions. I was trying to do the education. I was trying to, really get down to the underlying issues and reasons for, whatever it was that was going on with each of them. But it's just not sustainable in that model, right? So direct primary care allows itself for that. But I think people in general, where a good place to start is, if you like your physician and you have a great relationship with your physician, whether they're direct primary care or not, start with them, right? Even if they're in the traditional system, start with them. Ask those questions and say, hey, doc, this is what I'm looking for. I'm actually more motivated. I want to more, personalize my health, optimize my health. Do you have the resources in your practice to offer me the things that I need? And if the answer is yes, great. Maybe they do, right? If the answer is, well, unfortunately, all I can do is refer you out to a dietitian, to this, to that, then maybe you should look into a direct primary care that could potentially do that all within the practice, because they're going to have more time to do that. The physician themselves more likely will be able to do some of those things without having to refer you elsewhere. Yes, obviously, if clinically appropriate, we do referrals as well as direct primary doctors. But the whole premise of the model is that we're going to try to do as much as we can. 70, 80%, there's different statistics of your overall healthcare needs that we'll take care of in your direct primary care clinic with your direct primary care physician. I like to say that we'll take care of 99% of your primary care needs, right? Because literally that's what we're doing. And so, but again, sometimes people do have a hard time switching physicians because of the relationship that they have. So just start with your current physician and go from there.
So you brought up a key point there, and I want to kind of dovetail off of this, and that is one of the more interesting things that I found out in direct primary care is that I no longer go to any specialist. So at one time, I was seeing my primary care doctor, and then I had two other specialists that I'm seeing. When that actually primary care doctors, even the ones that don't give you the time, they're actually trained to take care of those things. They just don't have the time to do it. And so with direct primary care, you're actually to fully utilize all of your training and take care of so many other things, just like the behavioral health or the mental wellness. Primary care doctors are trained to take care of a number of things, not serious psychological and psychiatry issues, but what the most common things that are out there, you guys can take care of it. It's just about having the time to do it.
Right.
But another issue, and this is a big one because people are referred out to this so many times, and then they find out insurance is not covering anything because maybe you end up with someone who is not even a physician per se that's doing this, and that is hormone therapies. Some of the stuff that's out there when people start having, we found out that your testosterone levels are low, you're going to need a treatment for that. I'm going to send you to somebody else. Well, yeah, I'm not going to that specialist. It costs $100, but I saw this ad in the paper where this guy can hook me up to some machine or do whatever. I can take this magic pill, but you never know what's going to happen then, right? But that's actually part of what can be done with direct primary care. Well, if you have the properly trained, I mean, I know that you're a lifestyle guy too, so you have that as well. But talk a little bit about that particular aspect of it, not just with all the things you can do, but in particular about hormone therapy, because that's a game changer for so many men.
Yeah. And we're learning more, over time that the importance of hormones and balancing hormones, right? We've known obviously for a very long time about menopause in women, right? On average,
right.
51 years old, that's when women stop having cycles or no longer able to have or bear children. Their levels drop to, very low, and that's God's way, the universe way, nature's way, however you want to put it, of saying, hey, you know what? That aspect of your life is done. But we now know too that men also go through some sort of menopause as well. In men, our testosterone levels, which is our main sex hormone, since that's what we're talking about, it's going to peak in your very early 20s. Then you'll be riding that wave for a while, but not a long while, because after the age of 30, unfortunately, your testosterone starts to diminish as well. Sometimes 1 to 2% per year. And so over time, depending on where your baseline levels were, if you were on the low end of normal, then by the time you're 35 or 40 or even 45, your levels could be significantly lower. And so that's when you start to feel perhaps sluggish, fatigue, can't think straight. You start having, different emotional lability issues or weight gain, etc. Right? Some of the things, for example, that we know of more so women can experience. And so more and more we're realizing that, hey, perhaps this is just like in women that can have a very early onset menopause. Men can as well. And so let's try to optimize those levels, right, to at least somewhat of where the average should be, which is very similar, I think, to women. And that way they can live longer, more productive years, especially when you're younger, and produce for yourself, for your family, for society. But it can help many, many aspects, even the mental health, as we were speaking about earlier.
Yeah, and that's kind of the first thing I thought about is, you don't feel yourself right. You're like, wow, I can't believe I can't do this, or I don't feel like I say I'm run down. I don't want to go to the gym anymore. I don't do any of these things. I'm gaining weight, and I care, but I kind of don't care, right? In other words, you're in this place, you're in this headspace, and don't understand exactly what's going on. And I mean, it can just be a runaway. It can be the snowball effect now, right? It's just snowballing into so many bad things. So what are the steps? What kind of steps should someone, if they're starting to get this, what testing, what conversation should they have? Where should they start to try to get back on track, right? Because this piece right here may be such a fundamental building block to get everything else back on track that we certainly don't want to overlook it.
Right, exactly. And so I do want to preface this that, everything that we try to do, especially, we try to look at it from a very clinical lens, right? Because there are all kinds of places out there that's basically their marketing strategy, and they just give the stuff to anyone that walks through the door, whether it's truly necessary or not.
Right.
The necessary part can be subjective, but we do have some good objective ways of measuring that. For example, we know that obesity can decrease your natural testosterone levels as well. And so whether it's the obesity that led to the low testosterone or the low testosterone that led to the obesity, that we have to determine, first of all, or try to determine as best as we can. From a evaluation standpoint, obviously, we always start with, vital signs, right? So check your weight, check your, compare it to your height and blood pressure, get your BMI. But then, for example, in my office, we do a body composition analysis. And so we'll actually do a 3D body scan of your entire body. We'll get measurements from your neck all the way down to your calves. And then through that, we can use an estimate of your percent body fat and percent muscle mass. There are other ways to do it as well. There's bioimpedance, where you stand on a platform, you hold onto something, and it shoots a very small electrical current to check your body composition. There's a DEXA, which is a machine typically used for bone density imaging, but it can also be used for body composition in other ways. So we look at your body composition in my office with this 3D scanner that we have. Based on that, then we can compare where you're at for your age and height and everything else to others, if you're on the healthier or unhealthier end. And then from there, we do blood work as well. We check your, obviously, testosterone levels, right? That's the main hormone that we're looking at. But we can also do a little bit more in-depth assessments, right? We check other sex hormones as well, estrogen, FSH, LH, for example. We can check for your adrenal function. We can sometimes look at your cortisol levels, which can sometimes be helpful. Sometimes that's a debate in the medical community, but regardless, I think it's something you could look at. And then from there, again, having that conversation about what's going on and really dialing in on what your current habits are and see if there are some things that need to be changed along with or without, right, any medication or hormone replacement therapy.
So overall, what we're really talking about, and I know this is no surprise to you, what we're really talking about in direct primary care in particular is very much holistic medicine, looking at everything as a whole, all the different components, whether it is your diet, all part of your lifestyle, right? Your diet, your living conditions, your job, your exercise or lack thereof, your body size, your obesity or the amount, your BMI, I guess is the best way to say it, all of those different things. And then when you put in that other piece of what is your hormone level, you put all of those things in together. And then, of course, whatever chronic diseases you may have, which could have been caused by some of the other parts of things that we just talked about as you go down that pathway. And there's another part that we kind of haven't talked about yet. And I kind of want to know your thought on this too. And that is hereditary, because I've heard different things on hereditary that in some cases, these things are just blamed on that because it's not really. And then in some cases, they really do have an impact on that. I understand the genetic things. That's a kind of a little bit different thing. The genetic, that's who you are.
Sure.
But just because, is it literally just because if you have family members that have had heart disease or say diabetes, then you're more likely to have that yourself? Or is it because you're more likely to have that yourself because of the lifestyle that your family had, that you're more likely to duplicate that lifestyle, not genetics per se? What is your thought on that?
Yeah, and honestly, Harlan, it's a little bit of both.
Okay.
You hit the nail on the head. Yes, there is a lot of conditioning or nature versus nurture type of a debate, and I think both are correct because again, a lot of these or some of these diseases are very lifestyle induced, poor lifestyle induced, for example. But we can't ignore that, yes, some of these do have a genetic predisposition. Now, that being said, we don't necessarily, just test for every single gene out there to see if you have it or not, per se. But the study of epigenetics is essentially the idea that we can, based on our lifestyle more than anything, and maybe even potentially medications, we can actually turn some of those genes on or off, right? Depending on what we're doing in our lives and with our bodies. And so, again, just because you have the gene, and I can give you a perfect example, the Alzheimer's gene, for example. We have a test, and we can do the Alzheimer's gene test, which can tell us not only if you're at risk for Alzheimer's disease, but also perhaps if you're at increased risk of heart disease or cardiovascular disease. But for Alzheimer's specifically, the studies so far have shown, and nothing is concrete, that even if you have the high risk set of genes for Alzheimer's disease, some patients don't develop the disease. And by the same token, others that potentially had the low risk genetic measurement ended up developing Alzheimer's disease. So again, that's that epigenetics that comes into play, that ability somehow, we don't quite understand it 100% yet, but we're obviously researching it, that you can turn off or on those genes depending on what's going on with your body and around you.
That's fascinating. It really is, because that gives hope, right? That gives hope to so many people who said, well, I found out years ago that I'm predispositioned to, so it's just inevitable.
Right.
And whenever you hear someone such as yourself come out there and say, well, no, it's not. I mean, if you keep doing what you're doing, it's inevitable.
Right.
But you felt like it was inevitable. So you said, well, there's no reason for me not to do X, Y, Z. Yeah, there is. Mm-hmm. Because if you keep doing this, you are keeping it turned on. But if you can do this, you can flip that switch.
Exactly. It's about making a change. And it's about looking at each person, like you mentioned earlier, with that, not only that clinical lens that I mentioned, but the holistic lens that you mentioned as well, right? And looking at that person as a whole. I've had patients where, hey, I don't think clinically testosterone is beneficial to you at this point, right? Maybe if we change X, Y, Z, because everything can have a negative side effect potentially. And so having that discussion, having that understanding, that education, that holistic perspective, at the end of the day is what's going to help each patient make the right decision, or at least an informed decision.
Yeah, absolutely. We just have a few more minutes left. So I'm just going to remind folks, if you have any questions or comments, please put them in the chat and we'll get to them if we have time. If we don't have time, anything you put in afterwards, then we can answer after the fact too. I have a question, and this is not just about men's health, but overall. And I think I think back on especially Medicare clients that I have, and it does seem to be more prevalent in men. But once again, I think it's because we just say yes. And that is the number of medications people take. It seems to me like in many cases, people are taking so many more medications. And tell me if I'm wrong here, but it seems like half of them are to counteract side effects of the other half that they're taking. And I don't get this. Why? I mean, why? What are we doing here, right? What are we doing that we're just, the answer is always another medication. It just doesn't. I do not want to take any. I'm taking one right now because my doctor convinced me that it was in my best interest. I don't want to take that one, but I'm going to because I believe my doctor is probably right. I just don't want to take any medications. Whereas I talk to other people like, well, what are we getting this month, doc? I can't wait for my new medication. What's up?
Oh my gosh. So the term for that, Harlan, is polypharmacy. Polypharmacy is when you have way too many more than likely medications that it's probably hurting you rather than helping you. Again, unfortunately, and yes, it is more common in the elderly, both men and women, but yes, men are almost more of a culprit because again, they don't ask less questions. But the system and the time factor that we've been talking about lends itself for that. I don't know if you can hear me, but patients go to one doctor, maybe their primary care doctor, and then they send them to a specialist, but then that specialist sends them to another specialist, and then that specialist sends them to another specialist. And they end up getting a prescription from every one of them. But sometimes it's a factor of, hey, I don't know what I'm taking because maybe it's a new medicine and I haven't learned what it is yet. Other times it's the, yes, I know I'm taking something, or I'm taking a cholesterol medication and I'm taking this, but they don't know which one. And then other times it's a side effect. Oh, well, your cholesterol medication is causing some liver issues. Well, here's this one to help with your liver. Or, hey, your cholesterol medication is bumping up your sugars. Well, hey, let's give you metformin to try to lower your sugars instead, which that can happen with some statins in some patients. And so the problem is that, and I've seen it plenty of times. I've seen it. I had a patient once that came in with 3 cholesterol medications, and I asked, "Are you taking all 3 of these?" Well, yeah. My primary care gave me one. My cardiologist gave me one, and the endocrinologist gave me one. And I said, "But they're all in the same class of medication, and they're all doing the same thing. How have you not killed your liver yet?" Right? And so we end up having that conversation and reconciling those prescriptions as best as we can. And we love to get records from specialists, especially if we are referring somebody, because we want to stay in the know of what's going on. If a medication was changed, a dose was changed, a new prescription was given, so that we keep that condensed prescription list as necessary and small as possible, as clinically indicated.
Yeah. It's just one of those strange phenomenons that I have noticed over the years that 20 years ago when I was doing this, people didn't have near the list that they do now. And you're right. It's amazing how many people will tell me they've got so many medications, they've lost track of what they're even for.
Uh-huh.
I don't remember what this one is. I think this is blood pressure. Well, if it is, that's the 4th one for blood pressure you've given me, right? Okay. Well, no, this one must be for cholesterol then. Well, you've already given me 2 of those as well. Okay. Well, I don't know. Maybe this is for my thyroid. Well, no, I'm pretty familiar with all the thyroid medications. That's not that. Let's Google it and see what that is. Yeah. And then you do it like, oh, I'm not even supposed to be taking this one anymore. This is the one he took me off of.
Right.
Oh, yeah. No.
Oh, yeah. I've seen that as well.
Mm-hmm. And then the other side of it, especially towards health plan cost, a lot of times we see people still continuing to get things filled that they never take anymore. And some of those can be very expensive medications, and they're just continuing. They may even have them on auto refill. They're just mailing them to them every month, and they haven't taken them in months. They don't even think about the fact that it's costing the health. It may not be costing them anything, right? But it's costing the health plan money because this stuff is set up to keep coming, and you're just wasting money.
Yeah. Now, let me ask you this, since you know a little bit more about that, does that happen only if the patient fills a prescription and actually either picks it up, or more often than not just gets it delivered? Especially since
It's right. It's usually when they get it delivered, right? Because if they're not picking it up, it just goes back in. It doesn't get charged.
Yeah.
But I've even seen it where people had it automatically charged. So they were paying, just say it's a $20 copay or whatever for 3 months of supply, but it was still an $800 medication.
Yeah.
That's what the real charge is. So the health plan's paying that for 3 months, but they're not even taking it.
Yeah. So that's what I wanted to make sure that your viewers, get clarity on, is that you have to pick up physically the prescription, but if you're not, then if you're just getting it mailed, that's an automatic charge to you.
Yep.
But more than anything, like you said, to the plan. You're paying one thing, but the plan is actually paying something very different.
But people don't understand that in most cases, right? I'm only paying $20. This is a cheap medication. If you're not paying the whole price, you don't realize how much that is. And then you say, well, but it's the insurance company. No, it's not. It's you and your employer. In fact, you wonder who got your raise last year? Blue Cross Blue Shield got your raise last year. That's who got your raise, because the cost of healthcare keeps going up and you're not doing anything to help it.
Yeah. They got your 10, 20% right there with your premiums every year.
Absolutely. Well, Dr. P, I sure appreciate all the great information you shared with us today. Folks, if you caught the end of this, I did see that we kind of had a few more viewers pop in here near the end. This will be replayed automatically, particularly on LinkedIn. So you can watch the whole thing over and over if you want to. I think that if you put the sticky note just the right place on the screen, you can just have to see Dr. P and you won't have to see me at all. It'd be a wonderful viewing experience for you. But man, I sure appreciate you taking time out of your day to spend it with me and the audience, and really share your extraordinary knowledge of this subject.
Thank you. I appreciate it. Anytime. I appreciate people like yourself spreading the word.
Absolutely. It's been a joy to get to know you guys, and I look forward to working some more with you in the future as well.
Yes, sir. Appreciate it. Likewise. Have a good rest of your day.
Yep. Enjoy yours too. All right, folks. Thank you so very much for being on this edition of Why Does Healthcare Suck? We are going to talk about patient advocacy and navigation in the September version of Why Does Healthcare Suck? So look for that invite, and we will be happy to share some insights on that as well. Everyone have a super blessed rest of the week. We are out of here.